Thank you, Cece, and my thanks to the organizers for the opportunity to present. I've actually had the opportunity to attend all 3 days of this meeting, and I must say I'm almost intimidated by the high quality of the talks that have preceded me. And so my goal this morning is to try to live up to that high standard. So I work in a laboratory that serves several purposes. We do clinical testing for a number of different groups, including our own hospital patients. We also do development work with a number of biotechnology firms, and we do clinical trial testing. And I want to point out that I do have a consulting relationship with Novartis, and I also have a relationship with Life Technologies, and I'll be mentioning both of these companies as I go along. I want to begin with a case. And for those of you who are pathologists in the audience, you'll recognize that this is a very high-grade malignancy. It developed in the brain of an unfortunate 42-year-old gentleman, and it was given a diagnosis of glioblastoma. He was treated with the typical trio of surgery, radiation, and temozolomide. But then at 20 months, something unusual happened. Suddenly, this same tumor appeared throughout his body. It was in the bone, it was in the lymph nodes, it was in the neck. We got a biopsy of the material. It was the same tumor. And at this point, we were all scratching our heads in the pathology department asking, what is this thing? We're really not sure anymore that this is actually a glioblastoma. Now, what name you put on it doesn't really matter. At this point, the patient was really in extremis. He had pain, he had pending cord compression, he had difficulty moving his right leg. He was admitted for this. We tried another round of chemotherapy and had no impact on his tumor. But during this time, we had been asked to go ahead and do some screening of his tumor for possible mutations. And to my surprise, up popped a BRAF V600E mutation. Now, for those of you who are not familiar with this particular mutation in the BRAF gene, it is the most common mutation in melanoma. 45% of cutaneous melanomas have this. And so one might logically think, oh, this is actually a melanoma. But the tumor didn't have any of the other standard markers that we think of for melanoma. And this mutation occurs in other malignancies. So this is not proof that it's either a melanoma or anything else. It doesn't settle the issue of exactly what this tumor is. But it does provide us with a target for treatment because there are drugs available that go specifically after this mutation. And we were able to get him on one of those drugs, a drug called dabrafenib. And the patient had a fantastic response. Left the hospital already feeling better, was able to walk into his next clinic visit, and then 2 months later, he emailed this photo to us. He was able to go out and marry his sweetheart. And so to me, this gentleman represents somebody with tremendous courage. He faces down a high-grade malignancy in the hospital, and then he goes out and gets married. Now, at this point, I'd like to be able to tell you that they lived happily forever after, but as you can guess, with a high-grade tumor like this and only treating it with one drug, resistance developed rather quickly, and he has since passed away. But this story illustrates some other issues. This gentleman had no insurance, so everything that we did here was basically pro bono. But if he did have insurance, it's not a given that we would have been able to test his tumor for mutations, because insurance companies are not automatically saying yes to this. And even if they had, and we'd done it, and we found the mutation, and we'd gone back and said, will you pay for dabrafenib, that's not a given either. And then if we would consider putting this patient into a standard clinical trial, well, many trials require that you know exactly what the tumor is. We didn't. So in many ways, this sort of case where we're trying to bring individualized cancer medicine forward illustrates many of the problems that we face in this system. So we've been looking for mutations in tumors, particularly actionable mutations, for several years. We initially acquired some experience on the Sequino mass array system. We were doing hotspot mutation screening, over 2,000 cases in a registry in which patients were consented. We've since switched over to next generation sequencing, and we have experience on another 2,000 cases. And we're using this primarily to support clinical trial enrollment, but also to find opportunities for patients, sometimes off-label. And we're doing this both in the university setting and for community-based oncologists, as I'll come back to. So the topics I want to talk about with you in particular this morning are, first of all, we have to be very aware of what we're putting into the assay before we do the sequencing. Garbage in will give us nothing but garbage out. I also want to talk about how targeted sequencing is a useful tool but it's not the only tool that we're using. We shouldn't think of it as basically the answer. It's just one important tool that is now taking place alongside of others. And along the way, I want to mention how we're using gene copy number now as another way to squeeze more information out of the panel testing that we're doing. I also want to discuss with you what is the actual clinical utility. We've gone back and looked at this retrospectively now, and I can assure you that, in fact, not all of the actionable mutations that we identify are actionable or are getting acted on. And finally, I want to talk a little bit at the end about the challenge of data integration. How do we try to move all of this forward in the future? There are, by some accounts, more than 500 targeted therapies in development. Some of them already in clinical trials, some of them already FDA approved. This is just a quick snapshot, doesn't do justice at all. But we're going after many of the principal players, the kinases that are important in signaling cascades, as well as many other molecules. And next generation sequencing, of course, is allowing us to do that. Now, when we first moved forward with next generation sequencing in the clinical setting, the first question we had to ask ourselves is, well, how much sequencing are we going to do? In theory, we could have done whole genome sequencing, and there are centers around the country that are doing clinical whole genome sequencing. And it's fantastic, you get all of this information. But my concern is that if we did this, this would be me, and I would just be drowned with information, and I wouldn't be able to get through it in a timely manner, and I wouldn't really know what to do with most of it. So we decided to do the opposite. We decided to take a very conservative stance and just develop small targeted panels. And we now offer the panels that are listed here, a 23 gene panel for lung cancer, a 37 gene panel for most other solid tumors, and a leukemia panel. And this is really just the focus of the work that I'll be talking about today. And we've found that it's practical to do this and to do it cost effectively and to get good turnaround times. And to do this, we've been using a multiplexed approach to developing the sequencing libraries, the AmpliSeq technology, if you like, and doing the sequencing on a semiconductor platform, the ion torrent platform. We like this because it allows us to get away with very small amounts of DNA, 20 nanograms of DNA, which is a tiny bit. And it's performing reasonably well. The lower limit of detection for mutations is around 5%, and that's adequate for most clinical purposes right now. Now, we do, though, have to pay close attention to what we put into these assays. Now, here's an example of metastatic melanoma in the lung. That nodule in the center, blue is bad, as we say in medical school. That nodule represents about 90% pure tumor, and it's very easy for the technologist then to scrape that tumor-rich area off of the slide, and that provides us with starting material for the sequencing that is very rich and will yield mutations very readily. On the other hand, it's not uncommon for us to get a sample like this, metastatic colorectal carcinoma, mesenteric fat, and really the only tumor cells that are present are these dark purple blobs. And I can ask the technologist to focus on just this region of the slide, but by doing that, I'm still going to only get about 10 to 20% tumor cells, and the rest of the cells are going to be inflammatory cells, stromal cells, and so forth, contributing wild-type DNA and making it more difficult for us to see alterations in the tumor DNA. And then there are samples like this, transbronchial biopsy. We're looking for lung adenocarcinoma. 3 fragments shown there on the right, and 2 of them have no tumor whatsoever. 1 small fragment with maybe 50, 60 tumor cells in it. That's simply not enough. We're not going to try using this sample. We basically say, thanks, but no thanks. Try to find another sample before we go forward with testing. Now, lung cancer in many ways is the poster child, or actually poster beast, for molecular subtyping because we've got lots and lots of new targets that have been identified in recent years. And they're relevant. We have FDA-approved drugs for EGFR and ALK alterations already. We have FDA-approved drugs for the targets all shown in green, but the drugs are approved in other cancers right now. They're not yet approved in lung. Still, if we can find mutations in some of these genes, we might have the opportunity to target them with some of these drugs, either on trial or off-label. And then we have the targets shown in red, for which there are drugs in clinical trials, and we anticipate that some of these will move forward in the future. But if we want to cover this waterfront, we think that next-gen sequencing is an important part of it, but it's not the only tool that we use. In fact, to look for translocations in ALK, ROS1, and RET, we use old-fashioned FISH, fluorescence in situ hybridization. It's a standby that works very well. It's sensitive, and right now we feel that this is a very good approach. And then there are things like P10 or MET, where we want to assess them more at the protein level than necessarily worry about the DNA. P10 in particular, I think, is better assessed by immunohistochemistry than it is by sequencing. Yes, you can find mutations in P10 by using our panel, and we do, but we know that our sequencing is going to miss very large deletions or even whole chromosomal losses, and we are not looking at promoter methylation, and these are other causes for the loss of P10 expression, which is an important regulator of the PI3 kinase cascade. And so the message here is that next-gen sequencing is important. It's the linchpin, if you like, for our approach, but we are using other technologies to supplement it in order to get the broadest possible coverage for each tumor that comes through the service. Now, along the way, we became interested in the question, can we approach the question of copy number alterations by using this next-gen sequencing approach? And because we were using an approach that's different from many of the ones that have been published previously, we felt we needed to delve into this a little bit more closely. So here you see in each of these colored dots the number of reads from each amplicon representing that particular gene, and most of the genes that we looked at in this particular ampullary carcinoma had 2 copies. But all of the reads coming from the KRAS gene were markedly elevated against this background, and this may represent amplification. So is that the case? Well, we've gone through and developed an algorithm and now vetted it against a number of other technologies, whole exome sequencing, correlation with FISH studies, correlation with array-CGH, and we've satisfied ourselves that indeed the algorithm is working quite well. Here, for example, in the lower left, we have copy number estimates based on array-CGH as compared with our algorithm from sequencing across these genes, and you can see that the amplifications nicely line up, correlate very well, the losses as well. And then just focusing on the HER2 gene, you can see that we again have very good correlation between these two very different technologies. So we've satisfied ourselves that this is working. We've even, in one case for the KRAS gene, gone back and done quantitative PCR as another way of assessing how well the algorithm's working. And again, we feel that it is working quite nicely. So we now incorporate copy number assessment as part of the routine for these small panels that we're running. And, but one thing we have to keep in mind, again, is how much tumor is present in the sample. And that's illustrated nicely by this particular study here. We started out with a sample of breast carcinoma that had 80% tumor nuclei in it, and then diluted it out with fractions of normal DNA from the same sample, and then asked, can we see the elevation in HER2, the amplification of HER2 that we knew was present by FISH? And certainly at the level of 80% tumor, 48% tumor, and so forth, yes, we can still see that. In fact, we can see it all the way down to 16% tumor cells in the sample. On the other hand, when you look over here on the left side, we have elevation of the DDR2 kinase gene. It's clearly overrepresented in this tumor, but not to the same extent as HER2. And so here, we actually need somewhere between 24 and 32% tumor cells in order to say confidently, statistically, yes, this gene is overrepresented in the tumor. And then when you look at the retinoblastoma gene, where we're now talking about loss of an allele, we actually need about 50% tumor cells in order to detect that. So the lesson here is that, yes, we can assess copy number in tumor samples, but we have to be very careful in interpreting the data and keep in mind what we started with. And that's why we have records in our database of every sample and how much tumor was present as estimated on the microscope. Surprises do come up. This is a metastatic breast carcinoma, and you can see that HER2 is present in the normal 2-copy range, but EGFR is significantly elevated in this particular tumor. We confirm this by FISH. All of the pink signals here represent excess copy number for EGFR. So that was quite interesting and a surprise to me. I wasn't aware that this can happen in breast carcinomas. There's very little literature on this, but it turns out that probably about 5 or 6% of ductal carcinomas do harbor EGFR amplifications. Many of them do not have HER2 amplification, and so this represents a new target, and there is one clinical trial now that's getting started to look at this question. So when we began offering our next-gen sequencing, we did have some discussions with our oncologists, both in the academic institution and in the community. And one consistent message came back to me. They said, whatever you report, make it short. Keep the report to just half a page, because I'm not going to read beyond that. I got 40 patients I have to see in the clinic today, and I'm not going to spend a lot of time reading all of this wisdom that you're going to put into the report. So we took them at their word. Here's an example of one breast carcinoma with 4 alterations that we identified, and each one has a simple 2 or 3 sentence descriptor. We mentioned some clinical trials that might be relevant for that particular alteration, and that's it. And I can tell you, after having done a couple thousand of these, I haven't had a single complaint of the report being too short. Now, we've also gone back recently and started asking the question, okay, what is the real clinical utility of doing this? And this is one snapshot that I did myself recently, looking at our lung panel, 23 gene panel, and just went back into our records at the university and asked the question, of the 55 cases that we analyzed, first of all, how many of them had actionable mutations? And the answer was 60%. Okay, so right away, 40% that we looked at, we didn't find anything of interest. Now, among the 60% then, what happened to those patients? Well, in many cases, about half of them, they're still undergoing standard of care. Okay, so the mutation testing might be relevant down the road when they need to consider treatment alternatives, but right now they're still on standard of care, and so it's basically just data sitting in the chart. On the other hand, we did have 8 patients for whom a clinical trial was considered. Unfortunately, they were not eligible for other reasons. We had 3 patients who actually were enrolled on a trial, and then 2 who were treated off-label. Now, that's just one experience. We've actually had a larger experience that we went back and looked at with our solid tumor panel. This is a 37-gene panel. We've run it on a good number of cases, and this was 632 that we looked back on in collaboration with some folks from the Cancer Clinics of Excellence. Now, CCE is a network of community-based oncology practices, many of them involved in clinical trials. They've been big users of our testing. And so together with them, looking back on the charts, and the patients had been consented for this, we were able to make some determinations. So first of all, we found that 57% had actionable mutations. And out of that group, we were able to get follow-up on 301 of the cases. And we asked, the first question was, were the test results reported before the last treatment decision was made? And in one group, 41% of the cases, the answer was no. And in fact, many of those patients, unfortunately, had already been referred to hospice or had died. So one of the early lessons to come out of this is you can't wait too long to do this testing, because it takes time to find the paraffin block at St. Elsewhere, have it sent to the laboratory, get this testing done. Even though we turn it around within 2 weeks, these things take time, and patients don't always have that time. Now, for those patients in whom the test results came back in a timely manner, it was considered. And in 38% of those cases, basically there was no impact on care. The patient was going to be continued on another round of chemotherapy or what have you. But in 20 or 21% of the patients, there was an impact. They did get enrolled on a trial, or they were at least considered for a trial before they were, and weren't eligible for other reasons, or they got off-label drug use. So when you put this experience together, then what can we conclude? We can say that if you use small panels like ours, you can find mutations in somewhere in around between 57 and 60% of all-comer solid tumors. The testing must be performed in a timely manner. If you don't deliver the information on time, you're not going to help the patient. And, based on current trial availability, drug availability, and so forth, all of the constraints that we're familiar with, we can say that we're influencing the care in perhaps about 20% of patients right now. Now, this is one of those numbers that kind of sits there right between glass half empty and glass half full. You can look at that and say, well, that means we're doing 80% of the testing and spending lots of money on doing that, and it's not helping anybody. But you can also look at it, and some of the oncologists that I know do this, and say, these are 20% of the patients for whom we don't have other alternatives, and this is 20% better than nothing. Now, the next question you can ask is, okay, these are small panels, 2 dozen, 3 dozen genes. What if you test more? And we haven't done this ourselves, but there's some literature out there, and I'm going to have one paper that I've referred to here. There is a commercial panel, large panel of 287 genes, and in the report from that particular company, they said that 76% of their cases had an actionable mutation. Now, our charges to insurance are around $2,400. That's not what we collect, but those are the charges to insurance. The charges from the company for their larger panel are $5,400. And so what you can see is that when you more than double the cost, yes, you do get an increase in the number of actionable mutations. That's a good thing. On the other hand, when we talk about balancing costs and the weight and the impact on our healthcare system, you know, there is somewhat diminishing returns as you make these larger panels or move into whole exome sequencing. Now, one of the things that I think is important is to understand the challenges that we face in looking at the variants and trying to make a determination as to what really is actionable. And I think this is perfectly encapsulated by this phrase, we need to provide knowledge, not just data. This is Dr. Elena Tova-Johnson. He's the director at the University of Michigan Molecular Diagnostic Center. And I think that really says it nicely. And here's a case that kind of illustrates the problem. 40-year-old gentleman, thymic carcinoma. This is a rare tumor occurring in the chest. Thymic carcinoma, no good treatment options. His tumor is sent off to a commercial laboratory. A large panel is run. And it's reported back in the top half of the first page, no actionable mutations. Now, I happen to know the oncologist who is serving this patient. He referred the report to me and asked me, would you take a look and see if there's anything else in there? I agreed with the findings in the report. P53, not actionable. There were a few other genes not actionable. But at the back of the report, there was a listing of variants of unknown significance, and one of them caught my eye, KIT Y646D. So it turns out that there are 6 case reports of KIT mutations in thymic carcinoma where the patients have been treated with KIT inhibitors like imatinib and sorafenib, and they've had very, very good responses. So we look carefully at this mutation, and yes, it's true. It's a variant of unknown significance. It's not in the literature. It's not in our database, and we've been studying KIT for years in the context of GI stromal tumors. And yet, it's in the kinase domain, and it's 4 amino acids away from a known hotspot that is drug sensitive. So I said to the oncologist, if you don't have any treatment options for this patient, and we don't have any trials right now, why don't you go ahead and try a KIT inhibitor? And fortunately, he was able to get the drug for the patient. And here you see the before and after PET scans with a marked diminution in the signal of the tumor. And the patient is now 10 months out and still doing well. Okay. Now, I don't tell this story to try to make myself out to be a hero. Not at all. I'm simply pointing out that there's information out there that isn't always represented in some of the public databases that we're looking at. And so the report that came out from the company was technically correct. This was a variant of unknown significance. But there was biology behind the scenes that was reasonable to link into this particular tumor and I think in retrospect, it was reasonable to try to treat the patient. And now we know with some reasonable certainty that Y646D is an activating mutation and is sensitive to drugs. This isn't perfect information, but it's pretty indicative of what may be going on. Now, how do we then come to terms with the mutations we're finding? We can look in public databases, and there's some great resources out there. My Cancer Genome may be familiar to some of you. And you can look up a mutation like the BRAF V600E, and you can get information about publications and drug sensitivities and so forth. And a similar site now put together by MD Anderson, very elegant site with beautiful graphics and lots of valuable information. And I do use these resources. The problem is that if you're sitting in a setting where you're trying to move cases through quickly, because after all, Medicare is paying me $18 to do the review of the data that I'm getting from these panels. So I need to be moving these through quickly. I need this information to come to me. I don't need to be looking for the information. So what we've decided to do is try to aggregate this information into a database, and this is just now coming online, and we have a beta version of it going. And the idea is that you will have information about a particular mutation, again, BRAF V600E, and related to the clinical context, malignant melanoma. If it's a melanoma, you're going to be considering these drugs If you're going to be talking about lung adenocarcinoma, then it's a different drug and different amount of data that's available with regard to that. If you're talking about colorectal carcinoma, again, a different context and different information applies. So it's our idea then is that to bring this to us when we're looking at it, a case for sign out, and then basically click on the things that are important for that report and populate it and send it out to sign out. We also are working on a tool that will help us to mine for clinical trials that are related to these mutations. Other groups have already have tools like this, and that's also important to try to bring it in so the report can be put together in a timely manner. Now, in order to do this, we've had to devote considerable resources. For a long time, I limped along with just basically one software developer working on this database, and I realized we were just not getting as far as we needed to. So this year, I was fortunate to be able to get some more support, and we now have 4.5 FTEs working full-time on this clinical genomics database because we think that this is where the future is. Everybody can generate sequence. The issue is dealing with the data. Now, I want to close with one last case, and I think this case brings to mind some of the other issues that are important here. This is a woman with a bronchoalveolar carcinoma of the lung. This is a variant of adenocarcinoma of the lung. She was diagnosed back in August of 2010. She was referred to our institution 2 years later, and at that point, we did some testing and found a BRAF V600E mutation, and that's now a familiar mutation to you. We also saw amplification of the MET gene in this particular tumor. Now, with this mutation, she was able to get on a trial of 2 inhibitors, a BRAF inhibitor and a MEK inhibitor both, and she had this response. The right lung, in the left side, we have the right lung whited out by tumor, and then 2 months later, everything has cleared up very, very nicely. And here's the patient with her son, enjoying the benefits of this response. And I'm not breaking confidentiality because this was in the local newspaper. So this is one of the kinds of stories where we like to say, aha, we found the target, we treated it, we had a great response, we pat ourselves on the back, well done. But actually, there's more to this story. And so I went back and looked at her chart, and there's a couple of other things that were going on. It turns out that when she was first diagnosed in 2010, she was actually treated with another targeted therapeutic, an EGFR inhibitor, and it didn't work. So I didn't know that when it first came to us. It also turned out that she had been treated with chemotherapy, and in particular, pemetrexed had been very, very effective. When she started that drug, her pleural effusion dried up, the tumor shrunk dramatically, and that impact lasted for over a year. Then she comes to us, and she gets on the targeted therapeutic, and it worked great, but only for 6 months. And at that point, the tumor progressed. She had to come off the trial. So we tried some other things. We put her in a couple other phase 1 trials, not particularly targeted to her disease, not particularly effective. We tried a MET inhibitor because of the MET amplification. That didn't work. Ultimately, she was put back on a BRAF inhibitor, a little bit of a response, and then since then, she has succumbed to her disease. Okay, so there are a number of lessons here. The first lesson is that amongst the targeted therapies, we have some understanding of what's going on. The EGFR inhibitor didn't work. Why? She didn't have a mutation in EGFR. The MET inhibitor didn't work. Well, why not? Well, BRAF is downstream of MET. On the other hand, the BRAF inhibitor worked, but only for a short period of time. Maybe the MET amplification was driving some signaling around that drug and allowing her to become resistant. Wouldn't it have been interesting to try BRAF and MET together as inhibitors for her? But we didn't have that opportunity. On the other hand, what about the chemotherapy? The best response, the thing that helped her the most during the course of her disease, was the chemotherapeutic, pemetrexed. Why did that work so well in this particular tumor? We have no idea. And would combining pemetrexed with a BRAF inhibitor have been really the ultimate therapy here? We don't know. So when I look at cases like this, and in many ways this is a somewhat simple case, I begin to feel that we're going to be struggling for a long time to try to answer these questions because this is N of 1 medicine, and yet we don't really have the room, the freedom to practice it the way we might like to. The idea is, well, we need to set up a clinical trial and combine pemetrexed with a BRAF inhibitor. Fine, but these patients are very uncommon. How do you do that? Yeah. All right, so very quickly then to summarize, I've talked about how small targeted panels can deliver options for patients, and it can be done in a cost-effective manner. Microscopic assessment of the tumor is critical. You have to know what you're starting with in order to interpret the data with any sincerity. Copy number can be done, but you have to, again, be careful. We think that, a snapshot in time, but based on current trials and current drug availability, we're seeing about 20% of patients being potentially offered new options as a result of this testing approach. Maybe that number will go up in time. But most of all, we need more clinical follow-up data, and we need to be able to integrate this omic information all together in order to better understand what are all the options available for our patients. It's not just next-gen sequencing, and it's not just targeted therapies. So I want to thank all of the folks in my laboratory who've contributed to this work, as well as the folks who've been helping us to support it. Thank you for your attention, and I look forward to your questions.
You have a lot of questions here, Dr. Corless. So we'll try to tick through a lot of good questions too. So clearly a topic that our audience is very interested in. Let me start with one from them. Is there any advantage to sequencing the newly diagnosed cancer patients and not just advanced cancer patients?
Well, so there are, of course, markers that we need to know about right now in newly diagnosed patients, particularly in lung cancer, for example. We need to know about EGFR and ALK, because the therapies for those targets need to be used up front. They're used instead of chemotherapy, and so that's regarded as standard of care. One could argue that it might be worthwhile broadening that testing right now, instead of just looking at BRAF and ALK and saying, well, let's go ahead and see if we can uncover a ROS1 or a BRAF or HER2 mutation, and maybe preferentially put a patient into a trial earlier, rather than just putting them on chemotherapy. So I think, yes, in some circumstances it's worthwhile, but it's not true for all tumors. For example, malignant mesothelioma, we've not yet found anything that I would use to target a patient into a trial rather than do standard of care.
Okay. In your experience, what is the estimated percentage of cancer patients who benefit, talk about improved survival or cure rates, I suppose, from panel testing?
Okay, so that's something we've not established. Our retrospective data was basically looking at how was the data used, not at the outcomes. We haven't had the opportunity to do that, and that's actually much harder. What happens is that the patients get enrolled in the clinical trial. We're not necessarily at liberty to delve into that information or to share it because they're on a trial and it's being run by a pharmaceutical company. So aggregating that information right now is a major challenge.
Just a point of clarification in terms of the clinical panel tests that you're doing, are you sequencing tumor and normal tissue or just tumor tissue?
No, we're just looking at the tumor tissue. And when we're studying this small number of genes, we're fairly comfortable with what the background is and what the polymorphisms are. And it's really not necessary to run the normal.
Curious what sorts of factors might influence the oncologists when they decide to order molecular tests on patients with tumors, and are you in regular dialogue with those docs?
Yeah, absolutely. In fact, during the first year when we began the testing back in 2013, I visited 12 of the oncology practices myself in the community, and I would start talking about panels and genes and so forth, and the very first question every time at the end of my talk would be, how much does it cost? And how much is my patient going to have to pay?
So maybe what's the answer to that? You touched on in that incredible story about the patient who got married and then sadly did not live. But what is the status in terms of reimbursement today? And is there any difference in the private payer versus Medicare world?
Yeah, so unfortunately that's quite a long story that could take a lot more time than we should take this morning. I would say in general, we are getting paid some of the time by some of the companies. We're being turned down. We do pre-authorizations, and we're being turned down routinely by some of the companies. And then from Medicare, we're being paid for Tier 1 codes only.
Which means?
Which means a small subset of the genes that are on our panels are being covered and are maybe breaking even at that reimbursement level.
What more do you think you can do, you, the scientific community, to try to make the case to payers of the value of this type of investment?
I've been very fortunate that I've had the opportunity to join an advisory board for the group at Palmetto, which is one of the major Medicare providers, to help to try to give them input as to the value of doing these kinds of approaches. Whether I'll have an impact, I don't know, but we're going to try.
Okay. Another question from our audience. Are you working on cell-free DNA or circulating tumor cell assays?
We are not. Our laboratory is not. There's other work going on at our institution in this area. I'm actually a big believer in plasma DNA testing. I think that the convenience of drawing blood from a patient in the clinic greatly outweighs the inconvenience of finding a paraffin block from somewhere else, and also gives you a snapshot of the patient right then and there, regardless of all the other prior treatments. And so I think it's quite possible that a lot of the paraffin-based sequencing that we're doing is going to go away in a couple of years.
Interesting. Another person asks you, how do you choose the genes on each panel? Is it a matter of clinical relevance, and if so, then how do you define that?
Yeah, so this is, when we first developed the panels, we went back to look at the literature, and in each of the cancers that we wanted to try to cover, and we asked what are the genes that are reported most frequently and which drugs might be relevant to those, and came down with these rather small lists. And it's basically, the genes on our list are by no means unique. Many other groups are pursuing the very same genes for the very same reasons.
Yet another on this long list of questions. How are you tracking clinical utility data? Is it difficult to follow up with the clinicians on that?
It's extremely difficult to get the follow-up. I got the 10-month follow-up on the gentleman with thymic carcinoma simply because the oncologist knows me and he sent me an email. It wasn't because I had a formal mechanism to go out and get that data or mine his chart for it. And that is by far the biggest problem that I face right now.
Why does the clinical context matter if you're testing based on mutations?
Yeah, this is a great question. So BRAF mutations turn up in a large number of cancers, and in most of them, it appears to be a reasonable target, but in colon cancer, it's not a good target. It's been tried and it doesn't work. So it's the same mutation in melanoma and lung carcinoma, in the gentleman with the brain tumor I showed you, where you get great responses, but in colon cancer it doesn't work because there's an upregulation of EGFR as soon as you try to tackle BRAF. So context does matter.
Okay. Good follow-up question here from your presentation. You mentioned tumor cell DNA getting masked by normal DNA in some of those samples. And so the audience member is asking if you've considered existing and emerging cell sorting, capture technologies to, in essence, purify the sample.
Sure. Yeah, no, actually, we've used laser capture microscopy to get material and then put it into next-gen sequencing. It does work, but the problem is it's so labor-intensive and it adds cost. And so if you're in a laboratory where you're trying to run dozens of samples through it each week, it becomes impractical to try to do that. So we've shied away from it.
Okay. Another one here. While exome genome sequencing is too much, that's in quotes from our question or information now, will that sequencing ever replace gene panels in your view?
Yeah, I met with our Cancer Institute director about 4 weeks ago, and his message to me was, you have to start doing clinical exome sequencing.
Oh, really? And why?
Well, he thinks that there are situations where we're going to uncover more information, and we're not going to offer it for everybody in every case, but we think that for selected patients, there will be utility for it.
Okay. And I think this might be, well, 2 more questions. One on the financing again. A request for you to elaborate on the $18 reimbursement by Medicare for informatics.
Well, so there's a standard code for a professional fee for interpretation of a molecular test, and the reimbursement for that is about $18.
$18. Whew.
Yeah.
And how long does that work take?
Anywhere from 10 minutes to 45 minutes, even sometimes an hour per case.
I think fast food might pay better in some
I'm not retiring
instances.
anytime soon.
No. And final question here. Why is the panel testing for hematological malignancies lagging behind solid tumors in the clinic. What do you think we need to do to address that?
Oh, actually, I'm sorry, I didn't have time. I wanted to concentrate today on some solid tumor experience because that's really where I concentrate my efforts. But we have an AML panel. It is really popular with our hematologists. They're using it for diagnosis of myelodysplasia. They're using it to find targets in AML. They're using it for minimal residual disease monitoring. Even though the test sensitivity isn't that great, they use it for MRD. And it's being done on every new leukemia and MDS case coming into the institution.
Dr. Chris Corless, thank you for, I think, answering more questions than anybody at this conference.
Thank you so much.
Thanks so much.